Hello and welcome everyone to another episode of Inside the Expert's Mind. And my name's Richard Cohen, and I'm Professor and Chair of the Digestive Disease Surgery Institute at Cleveland Clinic London. And it's my great pleasure today to interview Tommaso Falcone, who is Professor of who is Chief of Staff, Chief Academic Officer, Medical Director, Cleveland Clinic London. He is Professor of Obstetrics, Gynecology and Reproductive Biology, Editor-in-Chief of Minimally Invasive Gynecology, and past President of the International Society of Fertility Preservation. I have to say he is one of the most savvy men I've ever met, and I continue to learn from him on a daily basis. I hope that today is going to be of interest to us all. So just to tell you all that Tommaso is Chief of Staff, Cleveland Clinic London. We're opening our hospital. Our outpatient opens in September this year, and the main hospital opens in January. And this slide depicts our missions and principles and values. And just to draw your attention to our vision, which is to be the best place to receive care anywhere and the best place to work in healthcare, and also our guiding principles, which is to treat patients and fellow caregivers as family and Cleveland Clinic as our home. And I have to say that having worked with the team at Cleveland Clinic in London and in the USA, they really do see themselves as a big family, and it's a real pleasure for me to work with them. If we can take the slides off now, please, and I'll turn to Tommaso on our fireside chat without the fire and ask him if he could start. Tommaso, tell us about your childhood. I know you brought up in Canada and your journey into medicine.
Well, I started, my parents were Italian immigrants. So they moved, the whole village moved from Italy to Montreal in Canada. And in Canada, I went to McGill University and trained at McGill University for pretty much everything. No one in my family went to, were doctors. And in fact, no one in my parents or aunts, uncles, etc., actually even graduated more than high school. So I was the first one to go to college. The interesting thing about Montreal was it's extremely diverse, which I enjoy, and that's why I like living in London. I like the diversity, and every day, see, I spoke Italian with my parents, my uncles, aunts, etc., and I went to English school. McGill University is English. And of course, but my patients were French, so mostly French. And they were, so therefore every day we spoke 3 languages. But I went to Cleveland Clinic when 25 years ago, and I was offered to be head of reproductive medicine, which is something I trained, and minimally invasive surgery. So from McGill, I told we were going to Cleveland from Montreal, and I told my wife, I said, we're going to go for 5 years. We're going to build a team, and then we're going to go back to Montreal, where our parents still are, and our friends, family, everybody. And that was 25 years ago.
Wow.
So it's not that I lied, but it's just one thing led to another.
She's still going to hold you to it.
Yeah.
I often get asked what's a nice boy from North London doing as colorectal surgery, and my stock reply is where there's muck, there's brass. But I'm not sure that you can apply the same to gynecology. So if I say to you, what made you go into gynecology, and furthermore, why did you want to then specialize in reproductive gynecology?
Well, I went to the gynecology because I was interested in women's health. You know, at the in my immediate family, growing up, they didn't speak very well. They didn't speak the languages, so French, English. They spoke Italian. So at a young age, I was translating a lot of things, and at the same time, women's health was really not a priority for the healthcare system in Canada. So you sort of lean into it and saying, okay, this is very important. I was interested in medicine and that in particular. Then when I went to the obstetrics and gynecology, I was very interested in reproductive biology. I found it fascinating. But surgically, see, when I started, finished my training was 1990, and at that time, minimally invasive surgery had not taken off. And so I decided, this is an interesting aspect to do minimally invasive surgery. And nobody wanted to do it because it took a lot of time. I don't know when you started, Richard, but at that time they would send me all these endometriosis cases, and they said, "Oh no, like just to cut and get in." And I said, "No, it's very, very interesting." So it sort of evolved that way. But I was at the right, as in most things in life, you have to be hardworking and interested, but you have to be at the right place at the right time. And I was there when minimally invasive surgery was taking off, and I was just part of the group. And that actually goes with, when I was in Cleveland, robotic surgery was taking off. So the first publication in gynecology in the world, it was from our group, because the robotic company came to Cleveland Clinic in 1999 and said, "Look, do you want to start a clinical trial?" And I said, "Sure, why not? I don't know if this technology is going anywhere, but I'll try." And so I did that. And the same thing went for the uterus transplantation program. They said, we should start. And I said, "Okay."
So how do you start? So just say, I remember with in the United Kingdom, if you say to a patient, well, I want to try something really new and high tech, would you mind being the first guinea pig for me to do that? They're like, where can I sign? They're desperate to be part of it. What sort of processes did you have to go through, firstly in terms of the robotic minimally invasive programs, and then with the uterus transplant program? How did you get to do that in humans?
Right, for the robotic transplant, as in most technology, believe it or not, it's the patients that push the doctors more than and the other way around too, I guess. But certainly, like a lot of patients would say, like, "Are you the one who does minimally invasive surgery for endometriosis?" They have a website, they have advisory groups, patient advocacy groups, and like especially for endometriosis, they're really very focused, on like you should go see this person. So the patients are the ones. And then at that time, like when I was starting robotic surgery, everyone was interested in a minimally invasive approach, but what their main interest was cardiac surgery, because cardiac surgery was the maximum surgery that you can do as an open procedure. And they said, "Okay, we should try to minimize the surgery," but they felt that the surgery was too complex immediately, so they started it in gynecology and urology. And for this reason, patients were the ones that pushed it. For the uterus transplant program, I can only tell you that we never advertised one thing. We just put the trial on clinicaltrials.gov. So just to tell you, patients are looking at what's going on at clinicaltrials.gov, which is the site where you put the trial. We put the trial on, and 300 patients called and said, I want to be part of the trial." There's also societies, like I said, patient advocacy groups are the ones that are pushing, like the Rokitansky Society, which women born without a uterus. They were the ones that said, like, this is important, and we should move it along. So again, I think that a lot of things you get into it because often patient advocacy groups are very much in favor of this technology.
Tell us about the first. Here's a slide. Do you want to talk to this slide, Tommaso?
Right. So this is the first birth from a deceased donor uterus transplant in North America. It was actually the second in the world. So we started doing uterus transplantation right after in fact, I went to Sweden to learn and so that's me on the right side, or the right side of the screen there with the glasses on. And the guy who's scrubbed in is Andy Tsakis, who's the uterus transplant, who's the transplant surgeon. And both of us went to Sweden, and he is the transplant surgeon, I is the gynecologist. And I went there very skeptical, and but the Swedes did an outstanding job of going through every step of the way, and the true pioneer is there. And I asked to speak to the patients who had the uterus transplant, because I had this sort of thought that perhaps they were being coerced into us, and I had so I asked the head surgeon there. I said, "I'd like to speak to all the patients that speak English, and I want to ask them personally, what motivated them, because such a complex procedure." And in fact, these were extremely independent women who had made up their mind, and I won't go into the clear reasons, and they wanted to move forward with this. So we did the first uterus transplant in the Americas, and then, but just to tell you how we did not have the first birth from a transplant because we had a complication of first surgery, and you have to learn from that. And then the deceased donor, because we do only deceased donor at Cleveland Clinic because potential complications from the donor. So we do deceased donor, and the complex part of the surgery, in fact, is in the donor rather than the recipient. The recipient is pretty straightforward transplant, surgery, easier than a liver, but the donor is the one which is the most complex surgery. So we felt that we didn't want to take a risk, and for this reason, we started at the deceased donor. Then in the world, there was one birth before us, which was from Brazil, and they pretty much put their program on hold. And this is our first birth, which is the first one in the United States, North America. And so basically, there's a bunch of transplant surgeons. And my role, the ones who are scrubbed around the patient were in fact the obstetricians. And then once the baby was born, in this particular case, we're removing her uterus. Usually we don't, but she had an accreta. And then I was part of the gynecology team that removed the uterus, so that was my role. But this one here was a culmination of a lot of people and a lot of, and this generates a lot of interest. In fact, we had done 8 transplants from deceased donors before we shut down for COVID. So the program was shut down last year, but we are reinitiating it now. And we've had four births. And as usual, the first birth, you can't get in the room because of the number of people that want to be there. And everybody in CNN was waiting. When we had the 4th birth, which was just recently, nobody was, was standard now, we've seen it all before. Let's move on to something else. So, and as you know, we learned a lot from inside because, Cleveland Clinic has a history of innovation. The first total face transplant was done there and in the world, and the total face, like some people did all other parts. And so we had a good team of transplant. So that was my journey towards that. And it was obviously fascinating.
And tell me, Tommaso, so in terms of my limited understanding of transplant, so normally the issues are technical because you've got to plumb the organ in and successful. So was it connected to the recipient's vagina, I presume? Is that
right?
So you could, and how did you put embryos in through that?
Right. So the question is that first of all, anybody who doesn't have a uterus, you can have a uterus. So in fact, in the future, for patients undergoing gender confirmation surgery, that certainly is an option for them. You need a neovagina, but it's not hard to make neovaginas. But the true technical part of this is the donor. The recipient is people born without a uterus or have a hysterectomy, typically born without one. It's a vascular anastomosis like they do kidneys. That's probably the similar one. So you just, external iliac artery and vein, and that's basically the vascular supply. The woman, the recipient, has a vagina, usually a neovagina, and we suture the donor vagina, part of the donor vagina to the recipient, and then we, suspend the uterus. Again, very straightforward. And then we do an embryo transfer about 6 months later. The true technical part is if you're doing living donor. In deceased donor, like we did a trial one as we reinitiated program just a couple of days ago. I went in and, for those that have seen this, after they cross-plant the aorta and everything is cold, we do like a radical hysterectomy, except we take en bloc the entire internal iliac vein and artery from the pelvic brim, go all the way down and scoop out.
Right.
Okay. So it's pretty straightforward. In a living donor,
you can't do that.
You can't do that. That's right. And in fact, the complex
soon
part,
to be deceased donor.
Yes, that's right. So what happens is as everybody knows, the uterine artery goes above the ureter, which is easy to identify from the internal iliac. And you take a piece of the internal iliac and move it medially. The problem is the veins, as everybody knows in the pelvis, they could be one deep uterine vein, or maybe just a bunch of venials, or a bunch of, they spread out. So therefore, you have to be very, very careful and moving. And that itself, the dissection of the deep uterine vein in all of the living donor procedures takes about 5 hours.
Right.
So the first 4 hours is everything, and then the last 5 hours of it. And they've tried to do it robotically. And just recently, I just reviewed another video of the robotic surgery, and it still takes them a total of 10 hours for the donor, because again, 5 or 6 hours is on the deep uterine vein. Now, some people use the ovarian veins. The problem with using the ovarian veins in women that are not, let's say, above 65, is that you take the ovaries. So you can't take the ovaries in women. We do not believe that you should take them certainly under 60, and therefore, for this reason, we do not take. We can take the ovarian veins, and then the transplant surgeons always have a trick up their sleeves, some extra veins in the freezer.
And do you take the ovaries from the deceased donors?
No, absolutely not. We never take the deceased, because genetically these patients are always the recipient's genetic patient, right? So the recipient,
Right.
these women born without a uterus, all have normal functioning ovaries, and so
Go on.
go
Yeah,
ahead.
sorry.
No,
So
it's important. Go ahead.
I was just going to say, so how do you, is rejection a real issue? Because with transplant, that's the big job. Well, we come to that in a moment.
Yeah, well, so rejection, so just to tell you that we can't take the ovaries. So we're working on, the true innovation is to figure out how to do living donors, but without necessarily taking the deep uterine veins. You can take you can't take the ovarian veins. In fact, in many trials, postmenopausal women are used, they give them estrogens because the uterine artery especially is very estrogen sensitive, and it shrinks after menopause. So they give them estrogen to make them dilated so you can do the anastomosis. So where do we fail? The failures of all transplants are basically thrombosis. They thrombose the veins, and that's apparently common in the transplant literature. So the two that one that we had to remove. So we did 8, 4 delivered, 2 were undergoing IVF and transfers, and the 2 that we removed, one was from a thrombosis. So they thrombose within the first 3 or 4 days, and that's the universal experience. The next is infection. Infection is not common, but certainly is a common thing. And our first patient was infected. She had an infection, a fungal infection, so we had to remove the uterus. Rejection does occur, but the transplant guys have really worked this out. So we did have rejection, and then there's a protocol for it. You give steroids, you give a bolus of this and a bolus of some other anti-rejection drug. So pretty much the world literature so far has not shown any removal from rejection of the graft. You have to remove the graft because of rejection. I'm sure it's no longer, it's no longer reportable. There's so many that have been done that, like nobody's going to, publish a case report on this. It's like robotic surgery. Like, if you have a case report, we're not interested. We're barely interested in case series. Yeah.
But is there an issue with giving anti-rejection drugs and teratogenic effects on the fetus?
Right. So we have liver transplants and kidney transplants, especially kidney. They've been around for 25 years.
Yeah.
And pregnant women have gotten pregnant without a problem for many years on kidney transplants. You just have to manage, their hypertension and a variety of other things. Liver transplants, we've had babies in women that have received a heart transplant. Right. So every transplant has. So it's not the transplant. I mean, obviously, the unique feature of the uterus in pregnancy, just to show you how, like we're only here because of the evolutionary advantage of that uterus. We put it in, and in a pregnant woman, it just grows to the, up to the xiphoid without a problem. And so, I mean, it's amazing adaptation. The organ is extremely independent and will grow and function absolutely properly. The births have been fine. The complications, they've had some patients with preeclampsia. Oftentimes is due to the fact that these women with Crooker-Syncytial syndromes have a single kidney, like they have pelvic kidneys and other. But so just to tell you, it's an amazing organ. In fact, if you remove those that reject, not reject, but we've removed the uterus, there's a 55 to 60% pregnancy rate in women that have a transplant. So it's pretty good.
Wow. Pretty good. Just so anyone in the audience, you can type questions into the chat box, and they'll be sent through to us. But so Tommaso, so you were pioneering with minimally invasive laparoscopic gynecological surgery, robotic surgery, amazing with the transplant program. Have you got another innovation left in you before you finally retire, and what would that be?
Yeah, well, that's a good question. There's always another innovation, and I think that for me the innovation is going to be the major issue that I'm really interested in, which is endometriosis. So I can only tell you that it's strange. You spend 25 years, like most of my research, publications, etc., has actually been on endometriosis, and like in all these publications in good journals, and people know of you that if you're in that field. Well, when we did the first transplant, we were in the front page of the New York Times, and I got more notoriety from that than I ever did about the uterus transplant than I ever did of 25 years of work in that. So just the moral of the story is the people read the New York Times front page more than they read most of the journals. But my passion has always been to figure out endometriosis, and I think innovation, like the radical surgery, and I'm going to bring it back to you, Richard. Like the radical surgery that I call, like the partnerships with colon and the colon surgeons and the urologists is really quite extensive. So to me, like working on innovative approaches that minimize damage when we're doing this radical surgery is the way that I think I'm working on as a next step. So it's like not the funny frontier as of these other things, but for me, having done a lot of this radical pelvic surgery as you have, Richard, we agree that this is not cancer. We have to figure out how to do this without harming, for example, the autonomic nerves and all that. So that's my main focus at the moment.
Yeah, when I first went to University College Hospital, the endometrious gynecologists, they used to call in the colon and rectum surgeon, and the first thing you would do is open the abdomen from the top to the bottom. And then myself and my colleague Alistair Windsor came across from St Mark's, and we started to help them do it with minimally invasive as you do. And as you say, we've learned that the less you do, the better, actually, and that if you do huge operations, there are consequences. So
especially with the autonomic nerves, which I see the colon surgeons have also adapted. At first, you just scoop everything out because we wanted to do radical surgery, but then we realized that that's not wise. So there are different innovative techniques for making sure that we don't take sometimes all these nerves and other tissues. So I think that's the main approach.
And can I ask you, Tommaso, if you could go back over your incredibly impressive career, are there anything in particular comes to mind that you would change if you could do it all again? Maybe nothing. I was just asking.
Yeah, well, I have that one is a hard question to answer as to what you would change. I mean, you would look back minor things, because I was chairman for 17 years before taking this job on, and the question is like it's all about people. Like there's a famous quote that people don't remember what you said or even what you did. They will remember how you made them feel. And sometimes so the people that's the way it is, and it's that quote has followed me. And so sometimes I say you have to make tough decisions with my patients and with the doctors that we hired, and sometimes you say like maybe I didn't make this person feel the way I should have, or a patient for that matter. So those are individual events more than career. Like I should have become a colon surgeon rather than a gynecologist. Yeah, But I think that is the main thing as I look back in my career.
Well, my experience, my
Go
experience
ahead.
with you, Tommaso, is that you always make people feel at ease. And I've been on, as we've been recruiting physicians to work with us in Cleveland Clinic London, I've always been very impressed by the way that I can't imagine that you've made anyone feel anything less than great when you've met them. So can I just ask? I've got in the last few minutes. What made you want to be chief of staff in London? You could have stayed in Cleveland, and you probably got into trouble with Mrs. Falcone, with Deborah, for shifting her not only from Montreal to
To
Ohio,
Cleveland,
but then to London.
to London.
What made you come in, and are you enjoying it?
Well, I am absolutely enjoying it, and so is my wife. So I have to tell you that certainly it's been great. So there's you have to be like everything else in life, like the robotics, the transplant. You have to be the right place at the right time. So I had been chair of OBGYN for 17 years, and I felt that it was time for someone else to take the job. And I loved my job. I love being chair of OBGYN. I love clinical medicine, as you know, Richard.
Yeah.
Like I cannot give up, clinical medicine. I don't have to do as much, maybe, but I don't. And I like my job, and more importantly, I liked all the people in my department and institute. There were some that were a little bit fringe, but they're still likable. Um, but I felt it was time, and the best time to go is when it's doing well. Like you don't want to go, and that's my advice to everyone. I said, leave the job when you're at the top. Like this department is humming, time to go. Not like, boy, this is a disaster, time to go. So that was the first thing. The second thing was, like I find it appealing to build clinical programs, and that's what the chief of staff role. The chief of staff, medical director, is obviously a UK regulatory thing, but chief of staff means we build clinical programs. That's what we do with the group. I recruited the leaders, like you and Olaf and everything. We recruit leaders, and then I just participate. But building clinical programs is, a very impressive contribution. And at the same time, so building clinical programs and the research and education component, that which is the chief academic officer, which I feel is an integral part of this, it was also very appealing. And I have to tell you that what's important is also the people you work with. And for me, my decision was made very easy because of the CEO was Brian Donnelly. Because I assure you, if it was someone that I could not work with, like we were talking about, we have to work with them. We know like they're not bosses, but they're a reporting relationship. You have to align. If you're not aligned, then you're going the wrong way. So when Brian got the job as CEO, I said, like I said, this, like is another parameter why I would like to go to help out in building this program and see it through. And what's important is to see it, obviously see it through. So it's building programs, I was satisfied with what I did, but I really loved my job. And just like with you, I know you enjoy your job. I mean, you're not leaving a job, your job that you have to come to Cleveland Clinic because you didn't like it. As a matter of fact, it's probably difficult. Most people find it difficult to move on because they love what they do, and more importantly, they love with the people. But a combination of that and and working with the group, specifically Brian.
No, it's been it's such a great pleasure to get to know you over the last few years, and it's been wonderful working with you and with Brian, both inspirational leaders. Just Tommaso, just to finish off, any advice for an aspiring young gynecologist who's watching this? Anything
Right.
you want to tell them?
So, tell her.
Tell her. Okay, yeah. Sorry.
Okay. Because most gynecology trainees nowadays are women, and so I can only tell you that it's, in my opinion, it's Richard, it is by far the best profession in the world. There is absolutely no way that I can tell someone, and just to tell you how I put my money where my mouth is, so to speak. My daughter just graduated as a gynecologist, and she so if believe me, most people will tell their kids, don't do this, don't do this. I instead said, you I think this is the most exciting thing, and you have to show it. You can't just say it's exciting and doing it. She had opportunity to do whatever she wanted. I think it's really the best profession, and for multiple levels. First of all, I think that from a contribution to society, contributing to women's health, which is really typically not a priority for many institutions, is very important. And so therefore, as a trainee, I can only tell them, hey, you're going to make a major contribution in the world if you want to go and keep going in gynecology. How to succeed is to make sure that you are committed, you find it exciting, like I do, and you don't burn out, because burnout is the big thing nowadays. And the way you don't burn out is making sure you have a good balance in your life. But my is to keep the excitement, because I have been excited about this specialty for 25, or if you include my training, 30 years. And again, I think I've done a reasonable job of making sure that everyone finds it as exciting as I do. And again, given the fact that my daughter went into it, I think I probably lived that.
You've almost convinced me to start a second career,
yeah,
Tommaso,
give you a
but
residency.
I do, as you know, delve into your
Yes.
regions on occasions, as it were. No, it's been a really fascinating chance to chat to you about your career, and particularly the work you've been doing on the uterine transplantation. I've got one question that's come up from the audience, if I may, and they ask, is it possible to use uterine transplant for patients who have uterine abnormalities as well as those that were born without one? Have you ever done someone who's had one that doesn't work?
Right. So the ones mainly would be those with intrauterine Asherman syndrome. The one in India that got pregnant, in fact, was a patient with severe Asherman syndromes. They couldn't fix it. If you look at our group of patients, about a third that requested transplants are those that have had an emergency hysterectomy postpartum, or those that where a uterus was removed for severe fibroids, for example. So there is no question. Also, androgen insensitivity syndrome. Those are the main ones. Rokitansky, hysterectomy postpartum, or for that. And in fact, in Sweden, someone with a very, very early stage cervical cancer was one of the patients that they did a transplant on. So yes, the indications are extremely broad, and basically a non-functional uterus is really what it is, more than absence.
Great. And Tommaso, any last words for people who are listening or who might watch this on YouTube moving forwards? Anything you'd like to say?
Other than to be excited of whatever you're doing in your career, and you'll succeed.
That's great. Tommaso, thank you so much for joining me on the webinar today, and thank you to everyone who's attended, and hopefully this will be uploaded onto our YouTube channel as well, so that you can have a look. And I look forward to seeing or having everyone with us again when we do our next episode. So thank you very much, everyone, and good night.
Good night. Thank you very much, everyone.